Good morning, everyone. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Welcome to today's webinar, The Transparency and Coverage Rule, Gaining Insights from Medical Claims Reimbursement Data. Now, this is one of the many webinars and forums that HPA hosted to keep members up to date on issues affecting our industry. So thank you for taking the time to be with us today. And thank you also to Lexis Nexis Risk Solutions, an HPA affiliate, for sponsoring today's session. Since CMS issued the final transparency and coverage rule, many individuals and organizations are learning the value of reimbursement data. In today's session, you'll learn about the value remitted medical claims can bring to health plans and how the information differs from what's been made available through the CMS ruling, which has more of the patient as the end consumer in mind. Now, with us today, once again from LexisNexis, is Jessica LaPiccolo, Strategic Account Executive. She has 15 years of experience supporting clients in multiple industries to address their communication needs. And also with us is Anya Machanjiewicz. She's been a part of LexisNexis Market View team for over 10 years in a range of various data analytic roles across different segments of the healthcare sector, including life sciences, specialty pharmacy, payer, and provider health systems. And she currently serves as healthcare strategy manager on the Market View product team. Now, before I turn the session over to Jessica, a couple of housekeeping items. First, as a reminder, HPA's annual conference covering New York takes place later this month on November 17th. We'll include a link to the conference in the chat, and we hope to see you all there. Now, for today's webinar, there'll be an opportunity for Q&A at the conclusion of the presentation. And this is an interactive session, so if you wish to submit a question, enter it either in the chat or the Q&A function at the bottom of your screen. And we'll try to get to as many attendee questions as we can. We are recording today's session, so at the end of today's program, we'll be making copies of the presentation available, and we'll send out a link to today's webinar. Now, with that, thank you all again for joining us, and I'll turn today's session over to Jessica. Good morning, Jessica.
Good morning, Eric. Thank you so much for the wonderful introduction and for those who are joining on today's session. We find that the payers that we speak to, a lot of claims reimbursement data seems to be that kind of secret sauce. So we look forward to sharing some of those insights with you today. But just to understand a little bit about LexisNexis and kind of who we are and where we are in the market. Anya, if you could just move to the next slide. Mm-hmm. So this will give you a little snapshot of really where we play in the healthcare industry and why we hope to be a trusted advisor for you today in terms of some reimbursement insights. So currently we have a footprint within over 90% of the commercial payers. So there's a very good chance we're working with you today in some capacity. But we cover everywhere from government to pharmacy to life sciences. And really our information and our data is the fulcrum of our solution. So it's really built on three major sets of data. One is our LexisNexis identity data. So that's where we have very granular information on your members. We also have the largest repository of medical claims. So we have over 2.2 billion medical claims accessible with our partnerships in the payer arena. And then we also sit on a provider and affiliation data with over 12 million providers and organizations. So we work with a lot of payers like you as well in regards to your member directory and really keeping it up to date. So, and all of those kind of filter into these four different pods, which are social determinants of health, provider data intelligence, identity intelligence, and claims analytics. For today's purpose, we're going to be focusing on that left lower quadrant of claims analytics and go a little bit into a deeper dive on what we see payers and how they're utilizing this with new compliance requirements and regulations. So without further ado, I'm going to turn it over to Anya to step us through today's presentation.
And actually, I think we have a poll question that we wanted to start.
Oh, that's right. Thank you.
Yeah.
Good, Anya. You caught me on that. That's right. So we wanted to make it interactive. We're going to open up with a poll question. There's two simple questions. So feel free to participate. It will give us kind of a pulse on our audience today.
And I'm not seeing any results on my end. I'm not sure if they're starting to pop up yet.
And your response is anonymous, so don't, feel free, like to participate. Okay, we could kind of review those a little bit later on in case it didn't come up right, but I'm hopeful that everybody on it was able to view it. Oh, here we go.
Oh, here we go. Okay. All right, quiet audience today, but that's okay.
That's okay. It just gives us an idea, and it looks like things are kind of split. So that gives us kind of an open canvas. So I think it'll be a format for a really great discussion. So
Yeah.
Anya, now I will formally tee it over to you.
Perfect. So I realize that in the audience, we might have varying levels of folks based on your experience or knowledge with price transparency or transparency and coverage. But I really just wanted to kind of do a high level setting the stage of what these acts are and why they're important. So first, on the hospital side, we have the Price Transparency Act, which is where the government has ruled that all hospitals and health systems have to post their allowed and billed remitted amounts for their top 300 shoppable services. So it can be different per hospital. Hospital of University of Pennsylvania might have a different top 300 codes or services that they perform from Jefferson Health out here in Philadelphia. So it's not going to be consistent between all of the hospitals, but they do have to post at least 300 codes worth of data. And there are 70 codes that CMS has mandated that as long as they perform one of these 70 procedures or services, that data has to be included. So potentially 70 codes might overlap across all of the hospitals. On the transparency and coverage side, payers have to post 500 services. Again, the allowed amounts and charged amounts of 500 services that could be a mix of diagnosis codes, procedure codes, or DRGs. And the nice thing is on the payer side, it's the same 500 codes that have to be posted. So there's at least going to be some consistency with the data that is being presented by the different payers. Both versions have to have machine readable files available, though the main goal of these acts is to have your average everyday consumer or patient be able to go online and access some of this remitted information, with the goal that they'll be able to see a little bit more into what goes into their MRI or their chemotherapy procedure. What are the rates that are going into it, and how does that compare and contrast with other hospitals or payers in the area? But we need a machine readable file for both of these versions. And that's the file that a lot of organizations, both on the payer, hospital, even life science side, they're trying to get their hands on to get some competitive intelligence, to learn what other hospitals or what other payers are posting as their allowed amounts, their negotiated amounts with different hospitals or physicians in the area. And these files, from my personal experience, are not the easiest to get your hands on or to access and read. So just something to keep in mind that we'll kind of revisit in this conversation. On the hospital side, as of August, only 16% of hospitals are considered to be in compliant with this ruling or in compliance with this ruling. There's different organizations that are tracking compliance rates. This is coming from one source that I've been utilizing since the start of this act being out or having to have their data posted on time. And they are very strict on what they consider to be in compliance and not in compliance. So if, for example, you have all of the different data fields available for your hospital, but you only have maybe a 50% fill rate, that would be considered not in compliance. So a very low compliance rate on the hospital end. And CMS is starting to put out fines. So it can vary anywhere from $300 to $5,500 per day that you are not in compliance with this ruling. And that does vary based on the size of your hospital. I'm not sure how they're picking and choosing which health systems to go after first, but the first big one that ended up getting a fine from CMS was, I believe it was Northside in Georgia, Northside Health System, and they were fined over $1 million for not being in compliance with this ruling. On the payer side, I fully expected that payers would follow suit of the hospitals and kind of drag their feet on not posting this data, not making it available. But I've been happily surprised to see that a lot of the, at least the larger payers, are posting their data. They are making it available, though, as I mentioned before, it's not the easiest to access or find, but it is out there. And for the payers that are not posting their data, CMS will eventually propose a fine of about maybe up to $100 per day, but I don't believe they have started issuing those fines yet. So within the payer market, we have a lot of customers who are in this space. And from the conversations we've been able to have with our customers, the ones who are looking to utilize the reimbursement data, whether it's coming from the price transparency files or from medical claims data, most of our customers are looking to utilize this data for network expansion and product design. So being able to use reimbursement intelligence to answer questions like, how do our rates compare to our competitors? How do our product design, how do our offerings, our plans compare to our competitors? Where's the market opportunity if we were to expand and grow into a new region? And what I think is the most valuable, what's the competitive makeup of that new geography if you are looking to expand? Because at the end of the day, a payer, you know everything about your own customers, but where that missing piece comes in, where claims data can help fill those gaps, or the transparency and coverage data, is learning about your competitors, learning about what's going on elsewhere outside of your own payer network. So that's so far where a lot of our remit conversations have come into play with our payer customers. And this is probably the most boring slide, but where I might spend the most of my time is just comparing what are the different data assets that are available if you want to utilize the payer transparency and coverage files versus what are the different data attributes that you can get from a medical claim. So whether it's us or another vendor, these are the types of fields that are filled out on the medical claim forms. So across the board, of course, both of these data files or formats will have the payer, the line of business. Some of the payer transparency and coverage files will include the plan level detail. I don't believe that is required, but a lot of payers are posting that information. On the medical claim side, at least for LexisNexis, we do not capture plan level, but we do both get down to that line of business level. Transparency and coverage, you have to post the NPI number of who received that payment, of who was on the claim. And I believe it's optional to include the TIN. So that would tell you where that claim took place. Medical claims, at least from LexisNexis, we include the NPI and the TIN of the facility and any physician who received payment. I do have a sample that I can walk through after the slides, and we'll be able to show you whether it was a facility or a physician who received the reimbursement claim. So we are able to give that additional level of detail. Of course, we both have procedure codes. Transparency and coverage does have that bonus of being able to provide data on diagnosis and DRG codes, which LexisNexis, we have focused in on the procedure CPT HCPCS market today with plans to expand that. But we do have every CPT and HCPCS code available. So thousands of codes that you could pick from to get this reimbursement detail on. Now, one field that we keep learning how important this is are the modifier codes. This is not required in transparency and coverage. For anyone familiar with how to fill out the claims forms, this is a completely optional field. So it's not even required on a medical claim, let alone as part of the transparency and coverage. But while the modifier code can tell you information about what happened as part of the procedure or the visit, or it could give you detail as to what type of physician was involved in that visit, the main reason why a lot of people look for the modifier codes is because it can greatly impact the reimbursement payment. So if you're going to be looking at comparing different rates between regions, procedure types, payers, what they cover, this is such an important field that we want to make sure we can pass through to our customers. So again, not required in transparency and coverage. And so far, I have not seen that it's included, though there may be some payers who are going above and beyond and starting to include it. Setting of care is a similar field. Initially, this was not required. I think it has since become a required field in transparency and coverage. And it is part of the standard claims offering that we have to include not just the name of the hospital or physician office that may have received a remitted payment based on where a claim took place, but really being able to filter on the setting of care. So how do claim rates compare if a procedure is performed in an outpatient setting compared to an ambulatory surgery center type of setting of care? So being able to look at it a little bit higher level for filtering type purposes. We have had a couple customers, not in the payer world, but we've had a few physician groups and hospitals utilize that setting of care to actually understand ROI. So if we were to get this piece of equipment and be able to start offering this procedure in office, how long can we expect until we can recoup our costs based on what the average remitted costs are or paid amounts are for that type of procedure? And I would imagine that would be a use case that our payer customers could utilize as well. Along with the payee, so that'll be either the hospital or the physician who received the payment, we do include all of their demographic information in terms of where they're located, so where their practice is located. In the transparency file, you'll get the zip 5, but you won't necessarily get the city where they're located. So you'd have to do a little bit of that digging in on your own if you wanted to get to that level of detail. In terms of time periods, we look at the most recent 12 months, but at least Lexis Nexis, we have history back to 2018. So we could look at historical views of remit data. In the transparency and coverage file, we're looking at, again, the most recent 12 months as well, but that data does have to be updated every month. So in a sense, if you wanted to start tracking the data and trends, you could download and re-aggregate the transparency and coverage files every month and start to create your own trends or see how the different rates are changing over time. That is something we also can do. We can deliver data as frequently as monthly if it were of interest. However, so far, a lot of our customers are looking for this data as a one-time deliverable because of how often or infrequent rates are renegotiated between the payers and health systems. Usually it's a one-time thing. We have had a few scenarios with our life science customers if they are putting out a new drug or a new device where they want to really track what the impact of the reimbursement landscape is pre and post launching that product. I could envision on the payer or hospital side that might be of interest as well to see, if there's a really, I'm thinking the SMA drug, Zolgensma, I think it's called, where it's like over $1 million price point. If you had something that was as extreme, as expensive as that, wanting to understand who else in the area might be covering this drug, either from the hospital or payer side. So I could envision that there's some other entities that would be interested in kind of tracking a pre and post launch of different drugs and products as well. Charged and allowed amounts available in both transparency and coverage and medical claims data. Our medical claims, our remitted claims that we receive, we do also get the paid amounts, which is so important. So having the charged amount, the allowed amount, it tells a piece of that story. You know, I feel like all of these are different pieces of a larger story. So it tells you some information, but being able to really know what was actually paid out is so valuable. It's the field that's going to tell you, you know, yes, we have negotiated amounts, and yes, this is what, you know, the doctor essentially requested as their payment. But what is the health plan actually paying out for these various claims or services that are happening? And that is not something that is going to be included in transparency and coverage. On that note, we can also drill into patient responsibility. And that's where, even though we don't include plan level detail in the claims data, it could give you a little bit of insight into what type of plan a patient might have based on what their patient responsibility was. So this allows us to see when that claim was it paid solely by the payer? Was it a mix of payer and patient cost? Was it fully covered by the patient? So you get a little bit of that, you know, deductible type of information there. The last few fields, denial rates and adjustment codes, these are more that whenever we talk to our customers about it, they want to see the data. They want to see what we have and what we can tell them. So denial rates, in the transparency and coverage file, you or the payers have to say the percentage or the fill rate of claims that are getting denied. And I think you have to have at least 20 claims to be able to report that, probably due to some similar HIPAA rules. You don't want to report on a low number. But in our data, not only will we tell you what those denial rates are and fill rates, but we can go that step further and tell you why a claim was denied. We can look at the adjustment codes. We have something that we call, it's like an adjustment code distribution report. So we put in our procedure code of interest and we can see all of the different reasons, all of the adjustment codes that were listed on those claims and who the payer was. And this is valuable to both payers and hospitals alike, because it can tell us if you as the payer have a service that you are not covering, you just denying coverage, maybe it's something that you consider to be not medically necessary, you could see either in your region or in a geography that you might want to expand into, are there other plans that are covering this treatment? And would that be a reason why a patient, a member, might switch to a different plan and get off of yours if you're not going to cover this? Again, that $1 million price tag SMA drug comes to mind. If I have a child with SMA, I'm going to go to the payer that's going to cover that service. No matter what other costs are involved, that is going to be the brunt of my healthcare cost in that year or for the next few years. So I'm going to make sure that I can do my due diligence and find out which payer is covering this. So that's why it's so valuable for payers to know, if you are not covering something, who else is, and could that impact your members moving from your health insurance to another. And then the last one here that's worth calling out is the claim level detail. So everything so far that we've talked about, including everything for transparency and coverage, is at the claim line level. So everything was reported per code, per procedure code, per diagnosis, per DRG code. When looking at the medical claims, we can aggregate it up and give you a reimbursement payment for an entire claim. So not just knowing that for this radiation procedure code, the average payment was, I don't know, $200. We can say for this radiation claim that included the $200 reimbursement for the actual treatment, what else did that patient need as part of that visit? Did they need any other medication? Did they also have a chemotherapy session as part of that claim that's been filed? So being able to roll up that data at the claim level allows you to see not just what these individual services are costing you, but what do these different visits as a whole, what are they costing you? And again, this is information that as a payer, you're going to know this about your own members and your own services, but you don't have the insight in what's going on with your competitors or with other payers who are, again, either in your same region or in an area that you're looking to grow into. So a couple additional data points here that's worth calling out. This is specific to Lexis Nexis medical claims, how we utilize that data to create reimbursement insights for our customers. When looking at the hospitals with their low compliance rates, we are not relying on transparency data to build out our data sets. So while the payers are so far more compliant than the hospitals, it's still possible that if we or if someone wanted to scrape all of the websites for where payers or hospitals are posting this data, you're not going to get a complete view. Not everyone has posted their data yet, or if they have posted it, it could be incomplete. When you're looking at claims data with our set of, we have 2.2 billion submitted claims, and about 2/3 of those claims, we do have the remitted claim as well. So because of how we collect our data, we are more confident that we can give a more complete picture as to what's going on with the remitted payments. We have more data points and we know which hospitals we're getting those data points from, which payers we're getting those data points from. And we collect this data from switches and clearinghouses. So again, we're not relying on payers or hospitals to self-report their own remitted payments. And we can utilize some different filtering criteria for our output. The number one thing that we do a lot is internally, we call it a co-occurring methodology. So it's basically when we're able to layer multiple diagnosis or procedure codes together. So again, transparency and coverage, everything is code level. So you're only getting the remitted metrics for a single code. If you were interested in knowing how those different rates could change based on what else is happening on the claim form, we could pull a co-occurring project. So I could tell you that the average reimbursement amount for an MRI is $5,000. If we wanted to see what the average rate was when you're getting an MRI with a primary diagnosis of back pain, that might now be an average of $5,500. If you are looking at MRIs with the primary reason being knee pain, maybe that jumps down to $3,000. I totally made up those numbers, but just for the purpose of that example, we can tell you how different reimbursement rates can, how they differ, how they compare and contrast based on filtering criteria onto these different codes. And then this is just a little bit more education of where our claims are coming from, or medical claims as a whole. Again, we're not relying on anything that the payers themselves are posting. We're getting our data from switches and clearinghouses. So when you're going in for your doctor visit, we start at step one here. You go in for your visit, maybe it's an E&M code, an annual visit of sorts. You have the codes entered into a claim form. Your doctor and or hospital, they're going to submit that claim. That becomes the submitted claim of an 837. When it gets moved over to stage 4 and 5, that's where we're collecting the data initially. So that's where we get all of our submitted claims, that 2.2 billion number. It is possible, claims can be denied, they might have to be changed and get resubmitted. But once it goes through the insurance validation process and the payment has been issued, that's where we are collecting our 835 remitted claims. And that is where we're getting all of that information to build out the reimbursement insights that we could then provide to our payer customers, our hospital customers. So we're getting data from different places, allowing us to have a different level of data integrity, data amounts than if someone wanted to rely solely on getting reimbursement information from the transparency and coverage files. While they're great, and in a sense, you could say those are free files, it's a lot of work to start compiling your aggregated insights if you're going to go in that direction and use that data. And there's just a whole lot more that we can tell you on that remitted claim form that isn't required, again, as part of transparency and coverage. So when we're looking at the remitted claims, this is some of the information that we're gathering. Of course, the CPT and the HCPCS code, and that can tell us, are you already an established patient? Are you a new patient? Modifier codes, units, which I didn't mention before, but we can tell you the units. So how does the payment differ per unit of a specific infused or injectable product? The allowed amount, the charged amount, the paid amount. We get all of that on the claim. We do not make any assumptions with those metrics that we're reporting out. We are telling you exactly what that claim form has told us. We do include the name of the payer. For the demo I have today, just to show an example of the impact of some of the fields, we have blocked out all of the payer names, but if anyone did purchase this data, we do include that, which aids in the competitive intelligence. That would be valuable for you guys. And the name or the facility of who received that payment. So who is the payer sending that remitted payment to? And of course, place of service was that other big one that is questionable if it's required or not. Initially, it was not. Now it looks like it is a required field and very useful. So before I jump into the sample, I did want to say how reimbursement insights, it's just part of the package of how medical claims insights can be useful to our customers to help you with planning for various healthcare types of activities. So not only are you able to grab the reimbursement amounts from the claim forms and figure out what's happening with our competitors, what's happening in this region or this state that we are blind to because that's not where we are located, you can use the claims data to tell you more about the patient population that reside in a certain type of region, or who are the types of doctors, who are the most common specialties that are practicing in this new state that we're looking to grow into. So the claims data can really tell you that whole package of just what's going on. What is the common comorbidities of patients who are in this new state? What are the doctors who are treating them? Who are the top performing doctors? So if you are going to move there, you not only now already have that understanding of, okay, this is how we would have to be competitive in terms of our reimbursement rates, but who are the doctors that we want to make sure will be part of our plan and will be, have their patients be part of our insurance plan? Who are those doctors connected to? Are there a lot of doctors here who are connected to several health plans? So we would have to, have a little bit more competition. It would be a little harder to get the patient member share in a certain region. Or are these doctors pretty much staying within network, within the same health plan? So if you did move into that region, you can trust that if you have a patient who is seeing a primary care doctor within your network, they're most likely going to be referred to another in-network doctor for their knee procedure or for their back procedures. And patient journey insights is looking at that patient. So similar to with the remitted claims, being able to see the claim level view of the payment, patient journey insights allows us to see what is going on with that patient. And it is all de-identified, so you won't know who the patient is, but you would be able to track different patients and how their treatments are going. What are their outcomes if they're starting on a first-line therapy for breast cancer, as opposed to a different first-line therapy, and really being able to see how the different treatment decisions, what's covered, what's not, what's covered as that first-line therapy, how is that helping the patient recover? And ultimately, in a sense, what is the cost of that patient, of that member? So again, information that you guys already have about your own members, but something that you don't have as easy access to that for your competing members. So just to kind of recap, once we layer in some of those other ways that claims data can help our customers, especially in the payer world, we've now opened it up to be more than just network expansion and product design. We're now also looking at, do you have the right members? Are there any gaps that you need to fill for coverage to keep members within your insurance network? What are the workloads? Do you need to hire or have more doctors of a certain specialty be part of your network? And are there ways to reduce overall costs, maybe by some of those treatment decisions that have to be made? And then I'm going to pause there. I'm going to quickly switch over, and then I think we can turn it over to questions. So this is just wanted to show a really high level view of a number of the payers that we are capturing from New York. So these are all claims that are coming through a New York facility or doctor receiving the payments, but this is just sampling to show you that we do have a robust coverage of the different payers coming from different states and different geographies. And hopefully our audience has seen their name here. And going into just a really quick data sample to show the impact of some of those different settings of care. And before actually getting into that, those machine readable files that have to be posted. They're posted through JSON extensions, which a lot of websites will tell you how you can easily convert files that are in that extension into a more user-friendly format. Coming from a data background and a data company, I have not been able to easily convert those files. Our systems, despite literally having a data warehouse with billions of records in it, I have not been able to convert those files. So while that data is out there and it exists, I do want to stress that it's not necessarily easy to use or get your hands on. And that's one thing I will say is a benefit if you're going to utilize medical claims data, whether it's us or someone else. We try to package it up nicely so our data is very easy to use. So this is an actual output of what our reimbursement data set would look like. This was a sample that we ran for a handful of counties in New York State. And just to show, we have our procedure code, we have our payer name, which is blocked out for this demo, but if you bought this data, you would receive the payer name. Line of business, who received that payment. And in this tab, I wanted to show the difference in payments based on the setting of care. So this is filtered for a single facility that received these payments. And I wanted to show these are very close, which is always, in a sense, good to see. But whether this claim, it was an E&M code for a established patient, 25-minute visit, whether the claim took place as a office setting of care, or it was billed as telehealth, or, if it did not have a setting of care listed on the claim form, the average amount for this claim is pretty consistent, about $112 to $119. So not too much variation there. But when we're looking at certain procedures, maybe a knee replacement procedure or, a spinal procedure. This is where just the difference between outpatient and ASC or inpatient and outpatient could have such varying rates that you want to keep in mind when considering what you guys will cover versus what other payers are covering in your region, or again, another region that you might expand into. And on the modifier side, same thing. We're now looking at a MRI code here. I think it's MRI or a CT code. Blinked out payer name, but the line of business we filtered for commercial. And depending on what that modifier is, let me scroll over a little bit, we can see how different the average rates are. So again, this is not a required field. That's why a number of these records do have null listed. We will tell you when there just wasn't anything listed. But it can tell you so much about what has occurred on that claim. And if you look at these numbers, I realize this is a small example, but when we have a modifier code of TC, those rates are significantly higher. TC is the technical component payment of this imaging scan. If you were evaluating the reimbursement rates of, just the imaging category alone without looking at these modifiers, you're going to get a very different answer as to what the payment landscape is than if you did drill into these modifiers. So that TC, that's the technical component. 26 stands for the professional fee tied to performing this this procedure or this imaging scan. So you can see that whether it's the actual, whether you're paying for the doctor or the actual technical side of it, you're either paying on average $120 or $650. So this is such an important piece of the puzzle for a number of therapy areas. Not every therapy area has modifiers being as important, but for certain areas, we want to stress how important this one can be. And we see something similar, when we're looking at E&M codes, the modifiers can impact, are you paying a resident versus a locums tenens doctor? So who are the different doctors that you're paying out for these services? And do you want to cover or not cover certain types of scenarios here? And with that, I'm going to take a break from talking and I'm going to turn it over to Eric to see if we have any questions.
Great, thanks, Anya. That was excellent. So as a reminder to our audience, if you have a question, feel free to add it to either the Q&A or the chat function. But while we wait for folks to send along any thoughts, comments, or questions, I'm going to kick it off. Anya, can you give us a little bit of insight into how health plans are utilizing Lexis Nexis's medical claims reimbursement information to comply with the coverage and transparency requirements?
Yeah, so right now we get this question from a lot of our payer and hospital customers is how can they use our data basically to respond to what they have to post? And the short answer is you really can't use medical claims as your answer for transparency in coverage. We do have a lot of the components. We have just about all of the components that are required, but because we package it up in a way where we're aggregating it at the total payer level and entity level, that's a little maybe too highly aggregated for what our payer and hospital customers are supposed to be posting. But we do recommend utilizing the medical claims, remitted claims for comparison purposes and to understand what you know about your own claims, your own claim universe. How does that compare with what the different switches and clearinghouses who process your claims know about you? And, do they have it right? Are we capturing the right number of claims? Are we capturing the right insights? So we see it more as a complement to your own data that you're posting for transparency and coverage, rather than being able to buy our data as the answer you can then throw up on that board or on that website. And yeah, go
Nope.
ahead.
Yeah, so, I mean, obviously, this is one tool that plans can utilize. Are there different approaches that that you're seeing plans take in implementing how they meet the coverage and transparency requirements?
Yeah, so I think the biggest thing, honestly, comes down to how large a payer is and how many resources they can dedicate to doing this. A lot of the payers who have already posted the data that I've been able to double check and vet out are those larger multi-regional, multi-state plans that probably have a larger team that can dig into their own remit data and post these different requirements, the different files that are needed. I would assume, I don't know for sure, I would assume that if you're a smaller regional insurance plan, while you have less data that you need to sort through to, be able to post these files, these answers, you might not have as big of a team. So I think the biggest implementation thing would be just how much time are you dedicating to this task, knowing it has to be repeated on a monthly basis versus, your everyday other tasks that our payers are having to take care of and do.
So there's obviously been a lot of conversation around the transparency rules, what consumers might see, and as we noted at the outset, this might vary a little bit as far as what might be in the public domain. Can you give us some insight into how the data may vary from what plans make available as part of their cost estimator tools for health plan members versus this information? Really, as an example, are there differences in how the information might be interpreted through machine readable file requirements versus consumer price transparency tools?
Yeah, so I can only speak from my experience of digging into these different versions of the data. I think the one difference, if we have a payer who is looking to utilize the transparency and coverage files, one thing that could be blocking them from the consumer version is not every payer, but some payers I've come across, you have to be a member to be able to access that consumer view of their data. So I happen to have Cigna. I can log into Cigna with my member ID and I can click through and filter around to check what my average is or what my estimated costs could be. But I think for Cigna specifically, you can only access that portion of the website if you are a member. So that alone could be a blocker. Not everyone can access that consumer view. But even when you're looking at the consumer view, I've seen a range of whether you have to include plan or not. So as a consumer, our options are basically you have high deductible plan A, B, or C. So if I can't input what my deductibles are, I might as well just figure it out on my own on a piece of paper rather than have to plug it into the consumer version of their lookup tool and their calculator. I think the other thing is, when looking at the consumer view, you are getting, I would say, the basics. You're getting what the code is, maybe where that code can be performed, and what your average rate is. On the on the machine readable files, there is a little bit more that goes into it. Oftentimes they'll include a minimum charge, a maximum charge. So that can help you figure out if you had access to that, you have the average, but really what's the mode, what's the median type of metrics that might actually be more telling of what your payment would be. So I think that's a big difference. Not everyone is going to want to dig into that level of detail, but if you had those different factors, you would know, yes, this might be my average rate that I could expect to pay, but what are the real numbers that go into that behind the scenes? So I think the different levels of metrics is the biggest difference between what the consumer sees versus what would be available in machine readable files.
So you have up on the screen the difference there it is, the different
Yeah.
requirements between hospitals and health plans on the transparency requirements. How might the data vary between what information you might get from a hospital versus what a health plan may provide?
So one thing I'm seeing again is plan level detail. Some hospitals are only listing out payers. I don't think I've seen a plan level detail from a hospital file yet, again, because it's not required. Whereas on the payer side, some of them are reporting on that plan level. So that can help you out a little further, depending on what you're looking for. If you're looking for that high level number, or you really need to know specific to me as a consumer, what am I looking at? The other thing with hospitals, I mean, I mentioned it before, it's the compliance. You know, if you want to know in my area, if I were to go to Jefferson Health and I want to know how much this procedure is going to cost me, they may not have posted their data. I might not be able to find that information. Whereas so far on the payer end, because payers are a little quicker to post their data, I can most likely find, you know, you have to start at the payer level, but I can find if my hospital's TIN number, and again, this, you know, you're kind of forced to be a little bit healthcare data savvy, but I can figure out where does my hospital sit for this payer. So I think just that overall compliance of how much data is there is the biggest difference between what type of data you can get out of hospitals and payer data.
So I'm going to just stop for a moment, see if there are any questions. We haven't seen anything come in through the Q&A or chat, so let me just pause for a moment. I know we're getting close to the top of the hour. So if there aren't any other questions, you know, Anya, one more question. So you talked earlier about ways plans might be able to utilize your tool to be able to look at what's going on in either their own service areas or other regions where they might not be, to determine who might be covering particular services or procedures. How might the data also be utilized to support care management efforts that plans have in place to support patients or members with acute or chronic conditions?
So, and that's probably where I'm going to put in a plug for utilizing medical claims over any of these transparency payment files. With claims data, you can look at the patient view for chronic care, for acute illnesses. You can see what are all of the different types of treatments or services that this type of patient needs. How often are these patients actually going in? It's one thing to have your treatment plan and what you would expect, but it's another to see what these patients are actually doing. And this is where we can layer in some other data attributes that you might not or currently wouldn't be able to get in transparency and coverage. You know, if you're moving into a rural area, do your patients who, you know, maybe should be coming in every month for a visit, do they have access to get to your facilities or get to their hospital every month? So how can you layer in additional data components into the claims data to get that big picture answer of just, you know, this is our plan. This is what this patient should be doing for the correct care, correct treatment. Are they able to do it? And you don't know that from transparency when you're just looking at this is the cost of that care, but are they actually doing it? Are they able to come in and do all of the appropriate things? And then these costs, the remit costs, you could kind of estimate how much that patient might cost you in a year. But if you can't depend on that data to tell you, are these patients able to come in? If not, how is their care getting worse? Or what are other comorbidities that we have to layer in? You're missing a huge piece of what's going on with that patient or that type of patient. So I think I may have gone a little off course there, but I think that would be one of the biggest pieces of how any data, remit data in particular, knowing the total cost of care could be valuable for understanding how to work with a patient, how to treat them, how to follow up with them. And that is something that would be missing from these transparency and coverage files.
So we do have one question from the audience in the chat. So Anya, what percentage of payers are complying with the rule? You had mentioned only about 16% of hospitals are complying. I know you've looked at, various plans, but do you have a sense of the percentage of plans that are meeting these requirements, or at least maybe a ballpark?
I wish I did. I was trying to find that in preparing for this webinar. I don't have an overall compliance rate, but I will say of the 10 plans that I tried to research and grab files for, I think 8 or 9 of them did have the data available. I just wasn't able to, again, because of the file size and format, I wasn't able to dig into it. So from my personal research, we have I would just say a high compliance rate, but I don't know an actual number across the board. If anyone knows that, do share it though.
So with that, I think that'll wrap it up. We don't have any other questions. Let me just give it another moment for folks in case there are any final questions. Well, seeing none in the Q&A or the chat, I want to thank, I want to thank Anya. I want to thank Jessica for today's conversation. This has been very interesting and insightful. And thank you again to LexisNexis for their continued support of the association and these types of webinars. We'll be sending along, as I mentioned, follow up today, a copy of the presentation, a link to today's webinar, and a brief survey asking folks for their thoughts and reactions to today's webinar. These types of evaluations help us in thinking about different programs, what's most useful to our industry. And then finally, as a reminder, we want to see all of you back in person Thursday, November 17th at HPA's annual conference covering New York. It's going to be a great program, a lot of important conversations, and we hope to see everybody in person. So again, thank you all for taking the time out of your busy schedules to be with us today. We hope you found it useful, insightful, and informative, and hope you have a great rest of your day. Thanks, everybody.
Thank you.